Welcome everybody to Grand Rounds. Our first speaker is Dr. Daniel O'Neill. Dr. O'Neill is an assistant professor of medicine at the University of Miami Miller School of Medicine. He completed his undergraduate education at Cornell University before earning a medical degree from Albert Einstein College of Medicine. Dr. O'Neill completed his internal medicine residency at Brigham and Women's Hospital, including a focus on global health equity and a Master of Public Health degree from Harvard University. He went on to complete fellowship for hematology oncology, as well as a postdoctoral fellowship in cancer epidemiology at Columbia University. His research has focused on various cancer-related topics such as treatment, global health, and epidemiologic trends. He is the principal investigator in various funded research studies and is the author or co-author of numerous manuscripts and abstracts published in leading journals, as well as author of several book chapters. Please welcome Dr. O'Neill.
There we go. Thank you. Thank you for that introduction, Jonathan, and thank you, Dr. Weiss, and everybody else for the invitation to speak today. I am going to try to speak about something that I think is potentially of interest to non-oncologists, mammography. I'm going to focus on potential benefits in terms of mortality reduction, potential harms in terms of overdiagnosis, and ways to mitigate those harms through the de-escalation of DCIS treatment. So for our clinical vignette, we have a 45-year-old woman. She goes to see her local GYN for a routine exam. She hasn't had any breast symptoms, no history of breast cancer in her family, and her clinical breast exam is unremarkable. She hasn't had a screening mammogram in a number of years, so her GYN refers her. And that mammogram shows left breast calcifications and an asymmetry spanning about 1 centimeter. She has a core-needle biopsy, which confirms DCIS, moderately differentiated, ER, PR positive. So just like any, for any screening test to be effective or useful, it has to be looking for a disease that meets certain criteria, and then the test itself has to meet certain criteria. So just as a reminder, the disease has to be something that has morbid or, excuse me, let me get a pointer here, has significant consequences, morbid or mortal consequences. Because you're looking at asymptomatic patients, the disease has to have a detectable preclinical phase, and that preclinical phase has to be long enough and prevalent enough that, that you actually have a hope of capturing it. And then perhaps most importantly, earlier treatment of that preclinical phase disease has to be effective at preventing the long-term morbidity and mortality that we're trying to avoid. The test criteria are pretty standard. It should be sensitive, specific, reliable, and feasible. When evaluating a screening study, there's a number of biases that can potentially color your evaluation. I think the one that most of us remember and that's the most intuitive is lead time bias. This cartoon illustrates lead time bias. So on top and on the bottom, we have a patient or two different patients. They both develop the preclinical instance of the relevant disease at the exact same moment in time. They then have the same natural history and they both unfortunately succumb to their disease at the same point. The patient on top undergoes a screening exam though, however, whereas the patient on the bottom is only diagnosed at the clinical presentation. Simply by the earlier detection of the patient on top's disease through screening, his apparent survival is longer than the patient on bottom, even though their natural history is identical. This lead time bias is a reason why survival of screened patients versus non-screen detected patients is not an adequate endpoint for trials looking at the effectiveness of screening studies. Length bias is a similar idea. Length bias recognizes the fact that for any disease, there'll be instances of more indolent, slower progressing disease. And these more indolent cases are more likely to be picked up during the preclinical period by any sort of screening exam that's done on a regular basis. And then that more indolent disease, those cases of more indolent disease are also more likely to have a favorable longer survival period. And so again, you're going to see a trend towards better survival in patients who are picked up on screening, even without any sort of modification of the natural history of the disease. The kind of most extreme example of length bias is overdiagnosis or overdiagnosis bias. Overdiagnosis refers to instances where the preclinical phase is captured or identified by a screening test, but that preclinical phase would have never advanced to actual clinically relevant disease, either during the follow-up period of a study or in a real-world scenario during a patient's lifetime. So this understanding of what overdiagnosis means is important as we kind of continue going. So screening mammography has been evaluated in a number of different RCTs. Most of them were performed in the 70s and the 80s. There's 8 large trials in total. This is all the RCT data we really will ever have for mammography. There's no more screening mammography RCT that are going to be conducted. And these have been evaluated in a variety or a number of different meta-analyses. The largest and probably most comprehensive was published by the Cochrane Group in 2013. They characterized the available studies on the basis of the adequacy of the randomization and the potential for biases coloring the results. And they identified these top 3 in green as having the lowest risk of potential biases, and then the remaining having some or serious problems. They then computed or put together composite risk ratios at 13 years of follow-up for both breast cancer mortality reduction and overall mortality reduction, looking at different age groups as well. When they took data from just the first 3 studies, the best randomized and best designed studies, they didn't actually see a reduction in breast cancer mortality or overall mortality in either age group with invitation to screening mammography. When they took data from all the trials, though, increasing the size of the data set, a difference in breast cancer mortality did emerge, both for the under 50 set. There was a 16% reduction in breast cancer mortality. And in the over 50 set, there was an even larger 23% reduction in breast cancer mortality. Overall mortality was still flat. In 2014, Welch and Passau out of Dartmouth put together a kind of real world estimation of the number of lives saved per 1,000 women screened, and they framed their findings in language that I think is easier for patients to understand. So first, they took data on the measured observed breast cancer mortality per 1,000 population from SEER. They took lower bound and upper bound estimates of the relative breast cancer mortality reduction from screening mammography. Their lower bound came from the Canadian trial, and just 5%. Their upper bound came from the 2-county trial, and they estimated a 36% reduction in breast cancer mortality. They took data from the National Health Interview Survey on the proportion of women screened in various age groups. And then they combined those numbers to first calculate the 15-year risk of breast cancer mortality in a unscreened population per 1,000 women, and those are displayed across. And then the 15-year risk with screening per 1,000 population. The difference between those numbers represents the absolute mortality reduction per 1,000 women, and those are on the bottom here. So to round these up to whole numbers and to put them into real world language, we'll go up to 10,000 women. So according to their estimations, 10 years of routine screening mammography would, in women who are aged 40 to 50 years old, would save 2 to 15 lives per 10,000 women screened. For women 50 to 60 years old, there would be 3 to 32 lives saved per 10,000 women screened. And for 60 plus, 5 to 49 lives saved per 10,000 women screened. So a definite, measurable, real reduction in breast cancer mortality, even with the lowest bound estimates. But I do think that these numbers are probably a little bit lower than many patients would guess, and even many providers would sort of estimate. So let's talk too about a potential harm from screening mammography and any screening test really, in the form of overdiagnosis. So the amount of overdiagnosis can be estimated using RCT data if the study design meets a couple of criteria. First, there has to be a long follow-up period after the screening phase where neither group in the study is being screened. And then the control group, the group that was not screened initially, can't be invited to be screened during that follow-up phase either. So we'll use this cartoon to understand how you then use RCT data to estimate overdiagnosis. So this here we have the cumulative incidence of our disease, in this case breast cancer, amongst the invited to screen group in the trial. And over the screening phase, we see a kind of rapid accumulation of new cases. And then we enter the follow-up period where there's no more screening going on and the rate of new cases tapers off. These are now just all cases presenting clinically. Meanwhile, in the control group, we just have the same steady rate of clinical presentation through the entire screening phase and the follow-up phase. So with a long enough follow-up period, all of the extra diagnoses during the screen phase in the invited to screen group should eventually present clinically in the control group. And when we get to the end of the follow-up period, we're going to have equivalent cumulative incidence in both sets. If we get to the end of the appropriate, relevant follow-up period, and there's an excess incidence in the, of disease in the invitation to screen group, that represents overdiagnosis. Those are cases that would not have become clinically relevant, right? So there are two mammography RCTs that had sufficient data, or had appropriate design rather, to allow for estimation of overdiagnosis. That was the Melmo trial and the set of Canadian trials. In 2013, the UK Department of Health commissioned their own analyses of existing mammography data, and that included an estimation of the degree of overdiagnosis based on the RCT data. And so using those two trials, they estimated that during the full follow-up period, about 11% of diagnoses represented excess cancers. And then over just the screening period, about 19% of breast cancer diagnoses from screening mammography represented excess cancers or excess incidence. Now, you can also make an estimation of overdiagnosis using retrospective or registry data. And that is based on a fairly straightforward idea. Recall, cancer screening is supposed to provide early detection of disease that eventually will cause morbidity and mortality. And early treatment is supposed to slow or halt the progression to more morbid disease. So what we would expect to see is an incidence of early stage cancers increasing with the institution of screening. But then importantly, we should also expect to see a decrease in the incidence of late stage cancers, because all of our early stage disease, or, all of these eventual late stage cancers are being picked up early and are being averted. So Blyer and Welch used that idea and published a fairly controversial article in the New England Journal in 2012 using that approach to estimate the degree of overdiagnosis from mammography. They took data from SEER, they took data from, again, from NHIS on the proportion of women undergoing mammography, and the number of eligible women from the US Census data. So they looked at the amount of early stage breast cancer defined as DCIS or localized disease, and late stage breast cancer defined as regional or distant/metastatic disease. They calculated a baseline incidence, baseline expected incidence, using data from the 1970s prior to the institution of screening mammography, and then an actual observed yearly incidence rate that they corrected for a little blip from widespread hormonal therapy use in the 90s. Then they calculated the difference, the observed yearly incidence minus the anticipated baseline times the size of the eligible screening population. They also provided some corrected estimates where they essentially changed the baseline. Their best guess was a steady increase in the baseline rate over time of 0.25% annually. And then they had a very extreme assumption where they increased the baseline rate at 0.5% annually and used kind of a higher floor to start with. So these are the relevant figures from their study. In the graph here, we see this is breast cancer incidence among women over the age of 40, so the screening population. And with the introduction of mammography in the mid-80s into the 90s, early stage breast cancer rates go up, and that's exactly what we would expect. Late stage breast cancer rates, however, stay relatively flat, maybe a small decline, but doesn't seem to be as drastic of a decline as we see with, or as corresponding to the increase in early stage disease. When they compare that to the pattern seen in women younger than 40, ineligible for screening, early stage and late stage are both flat. Applying some numbers to these graphs, so they estimate that the difference between the pre-mammography period in the 70s versus 3 decades later in the mid-2000s. For early stage disease, there was an increase of 122 cases of early stage breast cancer per 100,000 women. And the corresponding decrease in late stage disease was just 8 fewer cases per 100,000 women. Over 3 decades, that translates to 1.6 million additional breast cancer cases, early cases, and 67,000 fewer late stage cases. When they applied their corrections to the baseline rate, even with the most extreme corrections, there was an excess of still over 1 million early stage cases. And put another way, that translates to about 22% of the cases diagnosed in 2008, representing overdiagnosis. So this pattern is not just in the United States. Other countries have applied the same concepts to their own registry data. This is just one example from the Netherlands. And you can see the same pattern, very similar looking graph. So in the late 80s, early 90s, when screening mammography is introduced, stage 1 breast cancer goes up, in situ disease goes up, stage 2 to 4 breast cancer stays relatively flat. So as you might imagine, the Blyer paper in 2012 generated quite a bit of controversy. And there was a number of different responses. The first, there was a critique that there was a discrepancy between the trial data and the retrospective population data. And this is true, but it's really a degree of, it's a question of extent, not necessarily direction of the conclusions. Recall that the RCT data in the UK analysis still have anywhere from 11 to 20% overdiagnosis rates. There was a suggestion that sentinel lymph node biopsy, having been introduced in the mid-90s, presumably should have increased the incidence of regional disease because it's more sensitive to the detection of micrometastatic disease in the axilla. And that's probably true. That's a fair critique. Though it's not clear that it would explain the full extent of overdiagnosis seen in the Blyer paper. There was disagreement over the correction to the baseline rate and the suggestion that it should be as much as a 1% increase in baseline cancer rates annually. But even with the application of that very high increase in the annual breast cancer rate, There's still an overdiagnosis of 14%. 14% of cases. And then finally, there was a suggestion that DCIS shouldn't be included amongst overdiagnosed cancer cases, or the estimate of overdiagnosed cancer cases. That critique, I think, is flawed because DCIS is typically treated similarly to early stage breast cancer. Finally, there was a suggestion that the data that was used didn't provide any information on whether or not the women who were being overdiagnosed with these early stage breast cancers were actually the same women who were being exposed to mammography. There's no information on their mammography use. Harding et al. Tried to address that critique in a paper in 2015 that took county level data on breast cancer incidence, again from SEER, and county level data from the NCI on mammography uptake. And then they just looked at breast cancer incidence and its association with mammography uptake in women over the age of 40 at one point in time in the year 2000. So here are a couple of their key findings. So in this graph here, again, we have breast cancer incidence in blue, charted against the proportion of mammography over the past 2 years. So the amount of mammography uptake, with each dot representing the county. And you see a nice increase, a higher incidence with more mammography. Mortality is in red, breast cancer mortality. Unfortunately, we do not see a big budge with increasing mammography uptake here. Then on the right, it's this portion of the graph, but broken down into small tumors, less than 2 centimeters, and larger tumors, larger than 2 centimeters. You see that most of the increase incidence is coming from early stage disease, which again is appropriate. That's exactly what we expect to see with a screening exam. But there's not so much of a decrease in larger or later disease with increasing mammography uptake. So Welsh and Passau in the earlier paper I discussed about translating breast cancer mortality reduction into a real world scenario and easily understandable language. They in that same paper did a similar thing with estimation of the amount of overdiagnosis. Again, using lower bounds from the RCT data and upper bounds from the Blyer 2012 estimates. I won't go through all of those calculations, but a plain language example of their conclusions. So amongst 10,000 women aged 50 to 60 who are undergoing routine screening mammograms for 10 years, 3 to 30 women will avoid dying from breast cancer, and 30 to 140 women will receive a diagnosis of DCIS or early invasive breast cancer that would not have become clinically relevant during their lifetime. So if we want to maintain the very real breast cancer mortality risk reduction benefit from screening mammography, but want to reduce some of the potential harms from overdiagnosis, one potential approach would be to try to de-escalate the care of some of the lowest risk disease. And DCIS is the first obvious candidate for that sort of de-escalation. In terms of retrospective data, looking at the potential consequences of de-escalating DCIS care, a group from Dana-Farber in 2015 again made use of SEER data and just identified 57,000 women who had been diagnosed with DCIS and who had available data on their treatment. And then they simply just compared women who had gone for surgery versus women who had not had surgery for their DCIS. And they looked at their 10-year breast cancer specific survival. Women who got surgery are in solid, and the women who didn't get surgery are the dotted line. And for the full cohort, there's definitely a difference. It's not a huge difference in their overall survival, but it is a measurable and meaningful difference, and it's certainly significant. When they broken down by grade, for low grade DCIS, now outcomes are identical between the surgery and the non-surgery group. Moving on to intermediate and high grade, again, a difference emerges. Again, in both cases, it's statistically significant. and the difference gets larger in the high grade versus the intermediate grade. So they concluded that it would be reasonable potentially to recommend non-operative management of low-grade DCIS patients. And maybe more importantly, they concluded that an RCT of active surveillance for low-risk DCIS was justified. So those sorts of RCTs are ongoing. In the United States, that's the COMET trial. The COMET trial is enrolling patients with DCIS grade 1 or 2, ER, PR positive disease, and HER2 negative disease. Patients are being randomized to guideline concordant care versus active surveillance with just mammography and endocrine therapy. And they're reporting on breast cancer, progression to invasive breast cancer, mastectomy rates, survival, and quality of life. There are similar trials in the UK, the EU, and Japan. None have reported out results, but COMET trial results are expected potentially in 2022, so be on the lookout for those. And then just to wrap up, so conclusions, RCT data does show some reduction in breast cancer mortality with screening mammography. RCT data and retrospective data also suggest overdiagnosis of in situ and early stage breast cancers with potentially greater absolute number of overdiagnosed cases than breast cancer deaths averted. And low risk DCIS might be appropriate for active surveillance. The RCTs are ongoing. Just to check in with our clinical vignette, our patient she was referred for breast conserving surgery or surgical pathology confirmed DCIS without any invasive component. She was referred for radiation and prescribed tamoxifen for 5 years. Thank you very much. If there's any time left for questions, I'd be happy to take questions.
So, Dr. O'Neill, thank you very much for that very thorough and excellent presentation. I'm wondering if you can make any generalizations, or are we informed any from these trials about the role of screening mammograms in underrepresented minority populations? For example, we know, or my understanding is that in Black patients, for example, at the time of diagnosis, the breast cancer is usually much more advanced. Is there any reason to suspect there should be different recommendations in different populations? What roles social determinants of health play?
Yeah, that's a great question. So as far as I know, there is not any information from the RCT data that suggests that different populations should be treated differently. So, one thing I didn't include in this presentation I came across as I was preparing for it, that I'm not sure that it directly answers your question, but I think it's an interesting idea, and it's an idea that to me is fairly controversial seeming on its face. It was a suggestion that differences in screening rates amongst white women and minority women might actually create some lead time bias effect that informs their survival. So that some of the differences in overall survival that you see between different populations may actually be attributable to differences or to lead time bias that's introduced by the difference in screening rates. I mean, how you take that idea and you use it in a useful way. I mean, certainly we don't want to discourage, or I guess, certainly we don't want to undersell the extent to which there are very real differences in the care and the outcomes of cancer patients based on their ethnicity. To answer your question directly, I'm not aware of any reason why the recommendations regarding screening should be different. To the extent that screening represents integration into kind of full and complete and high quality cancer care and primary care, certainly it's important to emphasize inclusion for minority populations and other vulnerable groups. Yeah.
Thank you, Dr. O'Neill. Thank you very much again. Dr. Salter, can you introduce our next speaker?
Yes. So our next speaker is Dr. Rene Rico. Dr. Rico is an assistant professor of medicine at the University of Miami Miller School of Medicine. He earned his medical degree from Universidad Anahuac del Norte in Mexico before completing his internal medicine residency at University of Miami Jackson Memorial Hospital. He continued his training at Jackson to complete fellowship for pulmonary and critical care medicine. His research has ranged from topics such as extracorporeal membrane oxygenation, impacts of spontaneous breathing trials, and unique presentations of tuberculosis. He is the author and co-author of many publications in leading journals and has presented at a multitude of international conferences. Please welcome Dr. Rico.
Hello. Hello, how are you? Thank you for the presentation. Everybody can hear me?
Yes.
Perfect. So today, in addition to doing pulmonary ICU, I'm also the attending in the respiratory care unit that is located in South Wing 5, where it's our unit of where we treat TB inpatients. So of course, I'm going to talk about one of our cases that we have over there. So I'm going to start today with this case. This is a patient that was that came to us. So this is a 36-year-old male who was born in the country of Georgia. The time when we saw him, he had been in the US for about 7 years, but he had been living in Key West for about 2 years. Initially, he presented to us in January of last year. He was complaining of worsening shortness of breath for 3 months. Also, he had associated 20 pounds weight loss, generalized weakness, fatigue, fever, chills, and night sweats. His symptoms gotten worse just 3 months before he came to us admitted, but really his symptoms had started in 2018. At that time, he went to another hospital in Florida where he, according to him, he was treated for a left upper lung mass. He was told that he had a mass. Eventually, he was discharged, and there was not any further workup or not treatment. So he was referred to us from the DOH, from the Department of Health, in January 2020, and this is the first X-ray that we have on him when he first came. As you can see, it's a pretty impressive X-ray, I will say. As you can see, we have a large cavity in the left upper lobe. As well, we have bilateral nodular infiltrates in both lungs. As far as his past medical history, he had a history of diabetes, type 1, uncontrolled diabetes. His hemoglobin A1C was 10. Also some history of anxiety, depression, asthma. His asthma was pretty well controlled, just using as needed albuterol. His social history, he used to be a smoker. He quit about 1 month before his symptoms got really worse in January of 2020 when he came to us. He wasn't using any drugs. He used to work in Key West as a manager in a hotel. And as far as he knows, he had never been in contact with somebody who had tuberculosis. So this is the CT scan of the chest. I included some slide, a few cuts of the CT scan of the chest that we got after the initial X-ray. And as you can see, it's a very impressive CT scan as well. You can see in the left upper lobe, we have a large cavity. The cavity was about 7 centimeters by 7 centimeters. And you can see in the other cuts of the CT scan that we have bilateral infiltrates. We have multiple smaller size cavities, especially on the left lung as well, in addition to this large cavity on the left upper lobe. And we also have some bronchiectasis. So far, with all the information that I've given you, the epidemiological factors of the patient, the symptoms, and the imaging, of course, and one of the reasons why I'm talking is because one of the differential diagnoses is tuberculosis. So when are we gonna think about having TB? When are we gonna think about the differential diagnosis of TB, right? So usually we are gonna have epidemiological factors along with some characteristic symptoms. So some of the most important epidemiological factors is being born or living in an area with high rate of TB. As our patient, he was originally from the country of Georgia. Also an important factor, it's congregate living settings such as prison, hospitals, shelters, immunosuppression. And usually some of the most common symptoms and typical for presentation of TB, it's that the symptoms are gonna have long duration, such as our patient that he had intermittent symptoms for about 2 years, but also fatigue, weight loss, fever, night sweats. If it's pulmonary TB, we're gonna have prolonged cough, hemoptysis. And depending of the side of the tuberculosis, if it's extrapulmonary, we're gonna have different manifestations. So initially when he came, of course, he had a general blood workup, CBC, BNP, a sputum culture. He had an AFB. We had a positive smear. Later on, we had a positive culture, positive TB PCR, and a gene expert positive. I want to talk about more about these in other slides. So I want to review quickly how we diagnose TB, right? So a lot of times, one of the first contact that we have with somebody who is suspicious for having TB is the chest X-ray, especially as a pulmonology. And in the respiratory care unit, a lot of times they call us for X-rays, and we have to look at X-rays. In 95% of the cases of active TB in patients that are HIV negative, usually the findings are going to be in the upper lobes, right? In 95% of the cases, we're going to have either a cavitation or infiltrates in the upper lobes, but this is not always the most typical. I mean, it's not always the situation. In 30% of patients that are HIV positive, sometimes we don't have any infiltrates. Also, the chest X-ray is going to help us to rule out active pulmonary TB in patients with a positive tuberculin skin test or patients with positive quantiferon. As far as our microbiological diagnosis, we have the smear, we have the culture. The smear is usually very, very fast. We get the results rapid, but it's going to be only 40 to 60% times positive in cases of active TB. When we have a positive smear, we cannot say that the patient has tuberculosis. Other non-tuberculous mycobacteria can have a positive smear as well. So we also have to obtain, and we obtain the blood culture as well at the same time. The culture is going to be positive in 80% of cases of active TB, but it's going to take some time in order for us to get the result of the culture becoming positive. It's going to take, to say, 6 to 8 weeks in conventional media, and it's going to take 1 to 3 weeks by liquid media. After we have the culture positive, then we can get drug sensitivities, but this is going to even take longer. It's going to take 1 to 2 weeks after we have the positive culture. So one of the tests that has that we have has changed the way we diagnose and how fast we get we can start treatment on somebody who is suspicious for having TB is the nucleic acid amplification. This test, we have it available here in the hospital. It's usually going to take 2 hours. It's 99% has 99% specificity on smear positive cases. It's going to be up to 80% sensitive on 3 samples, and it's going to be a relative cheap test. It's going to be $30 to $50. It's approved by the FDA for smear positive cases, also smear negative cases, and untreated cases of tuberculosis, and it's going to help us as well to rule in non-pulmonary samples, right? But of course, the gold standard still for TB is when we get a sample is to send the smear, the culture, and obtain the phenotypic susceptibility. The molecular testing, the PCR, is not going to substitute the need for us to send these specimens to the lab, right? Even though the CDC does accept a diagnosis based on molecular testing in the right clinical scenario, right? One of the examples will be our patient who comes from a region where there's high incidence of tuberculosis. Patients had radiological findings, and he as well has typical clinical presentation of having TB. In 2008, some of the faculty in the Division of Pulmonary published this paper, Dr. Campos, Dr. Quartin, Dr. Abreu, Dr. Mendez, Dr. Ferreira, Dr. Ashkin. In this paper in 2008, they showed how a PCR can help to shorten the respiratory isolation in patients who initially get admitted to a respiratory isolation room because we are suspecting tuberculosis. Because there's going to bring problems, right? There's going to be problems with respiratory isolations. And most of the patients that are admitted to an isolation room, usually for TB, they are kept there for 5 to 7 days in average. in most of the hospitals, there's going to be limited availability of isolation rooms. And I've had the experience that it's difficult to admit, for example, somebody to the ICU to an isolation room because we don't have enough rooms available in some situations. Also, a systemic review in 2010 showed that patients that are on isolation, they tend to be seen less by the healthcare workers, meaning nurses, doctors, and in general staff that works in the hospital. They're going to have an 8-fold increase in adverse effects. The patient, of course, is going to have a negative perspective of their care while they are in isolation. And also, we've seen, and this I've seen in the hospital, they get delayed in getting proper procedures performed. Sometimes because they are in isolation, and people sometimes they're afraid of the patient having tuberculosis. And one of the most important things is most of the people who gets admitted and to an isolation room, most of them are not going to have tuberculosis. So the PCR has come to help us with this. Right now, and we need 2 negative PCRs to rule out TB or to get the patient out of isolation. And these 2 samples need to be at least 8 hours apart, one from the other. So going back to our patient, we got the sputum. We got a gene expert test, MTB PCR, which was positive, indicating that the patient had tuberculosis. And he had an RPOB mutation. The RPOB mutation is a mutation that indicates that the mycobacteria is resistant to rifampin. Subsequently, we tested the patient for the Hind study of the MTB-VR+, which in this study, we found that we confirmed the RPOB mutation against the rifampin. But we also found CAG mutation. This is for isoniazid, PNCA for pyrazinamide, and EMB mutation. So this patient was diagnosed with multidrug resistant tuberculosis, and he was resistant to isoniazid, rifampin, pyrazinamide, and ethambutol. So 4 of the first-line drugs that we use to treat for tuberculosis. I want to go over quickly about these 2 tests that I just talked about, the Gene Expert and the Hind testing. The Gene Expert is a cartridge-based diagnostic tool that we have available here in the hospital. We need only 2 milliliters of sputum in order to process one of these samples. We're going to have results in 1.5 hours to 2 hours. And the result is going to diagnose if the patient has tuberculosis, and also is going to test for rifampin resistance. So immediately in 1.5 hours, 2 hours, we're going to know if the patient has resistant tuberculosis, which is going to have clinical implication and is going to help us to, of course, to start as soon as possible the right treatment for the patient. Another diagnostic tool that we have is the Hind testing. We don't have these in the hospital, but we usually, when we send cultures, we also send to the state lab. The state lab is located in the University of Florida. And the Hind testing, it's also going to test for rifampin resistance, but also it's going to test for isoniazid resistance, 2 other mutations, the INHA and the CAG. And we have other diagnostic tools that are going to test for more advanced or for more resistance, such as fluoroquinolones and aminoglycosides that are like some of the medications that we have to use for multidrug resistant tuberculosis. And this is how, more or less how the report looks. Initially, we're going to have the molecular detection, the PCR. It's going to tell us if it's positive or negative, and then we're going to have the whole genome sequencing and the identification of the possible mutations in the sample. And I want to talk a little bit about resistant tuberculosis. Drug-resistant tuberculosis is a threat to the global TB care and prevention, and of course remains a major public health in some countries, especially countries like India, like China, like South Africa, and other countries where they have high incidence of drug-resistant tuberculosis. Some of the major categories used for global surveillance and treatment for drug-resistant TB are the rifampin resistance, MDR-TB, MDR-TB, or pre-XDR, that is MDR with additional resistance to fluoroquinolones, and XDR-TB. And I'm going to talk about these definitions now. So MDR-TB is defined as the mycobacteria that is resistant to rifampin and isoniazid. Pre-XDR, This is the mycobacteria that is going to be resistant to rifampin, isoniazid, and fluoroquinolones. And XDR-TB, or the extensive drug-resistant tuberculosis, is going to be mycobacterial resistance to rifampin, isoniazid, at least one of the fluoroquinolones, and to any of the 3 second-line injectables, such as amikacin, capromycin, or kanamycin. And this is going to have, of course, clinical implications. For example, the multidrug-resistant tuberculosis is going to be fatal in up to 50% of the patients that are affected. The cost has been estimated to be between $180,000 to $500,000. Usually these patients, especially in cases of XDR-TB, need to be treatment for 24 months. And it's estimated that they require at least 14,000 pills in order to complete the treatment. There's going to be other issues such as lack of medical expertise, how to treat these patients in the community. When somebody diagnosed multi-drug resistant tuberculosis in the community, these patients should be referred to a hospital or to an expert that knows how to treat multi-drug resistant tuberculosis. And most of these cases are seen in 4 states mainly: New York, Florida, Texas, and California. So when are we going to suspect that somebody can have resistance to tuberculosis? So resistance can happen in some situations. For example, somebody can get a multi-drug resistant or resistance tuberculosis just because the patient has contracted a drug-resistant strains of Mycobacterium tuberculosis. Another group of patients who can develop resistance TB, and actually is one of the most common, is patients who have already received 1 or more previous treatments and for different circumstances has not been the right treatment. For example, in patients that don't have enough resources, probably they don't have all the medications that are required in order to do the right treatment for tuberculosis, and sometimes they get treated for more than 2 weeks with 1 drug, and these patients can develop resistance. Another factor is the epidemiological factor. Of course, these countries in this map, like China, India, South Africa, the Russian Federation, they have higher risk of cases of drug-resistant tuberculosis. And who is at risk of having resistant tuberculosis? As I mentioned before, patients that have already been treated with TB drugs, patients in shelters, prisons, hospitals who have been in contact with other patients with drug-resistant TB, people who were born in other countries, especially in countries with high prevalent drug-resistant areas. When we are treating somebody for TB and the smears and the cultures remain positive despite 2 months of treatment, we get concerned as well that the patient can have or the patient develop resistant tuberculosis, and at this point we retest the samples for resistant tuberculosis. And as I mentioned before, another risk situation to acquire resistant tuberculosis is patients that haven't received the appropriate treatment for TB, usually for more than 2 weeks without the appropriate drugs. Also, patients with HIV, they're going to have increased risk of having resistant tuberculosis. And what is the clinical significance of resistant tuberculosis versus drug-sensitive tuberculosis? Well, if the mycobacterium is pan-sensitive, the chances of getting cured is going to be more than 95%. If it's resistant, it's going to be more than 90%. If it's resistant to isoniazid, if it's resistant to rifampin, it's going to be more than 70%. But if it's resistance to isoniazid and rifampin, so multi-drug resistance, the chances of getting cured is going to go, dramatically low to 50 to 57%. And even worse, if we have extensively drug-resistant tuberculosis, the chances of getting cured is going to go down to 10%. So in the ideal situation, we would like to have molecular tests for everyone, right? Especially for the countries with high incidence of tuberculosis, which usually are the countries that have less resources. And not all of them are going to have molecular testing available. Waiting weeks for conventional susceptibilities without having molecular results is below world standards. This shouldn't happen anymore. All the TB programs should at least have available RPOB analysis within 24 to 48 hours. And this is the mutation that I talked about, that is the rifampin mutation. And in this year, in 2021, the diagnostic order for TB is to obtain an AFB smear, culture, and PCR. So the PCR is becoming part and one of the very important tools of our diagnosis of TB. I want to show you this graphic that shows the cases from 2009 to 2019 of multidrug resistant tuberculosis. So as you can see, in these 10 years, there's increased detection, or we have diagnosed more cases of multidrug resistance TB. That's the blue line. And then the maroon or red line, you can see the patients that have been enrolled in treatment for resistant TB. So we are detecting more TB probably because we are testing more for multidrug resistant TB or resistant TB. But of course, we're not where we need to be. We still need a lot of work to do, especially in the countries with high incidence of drug-resistant tuberculosis. From 2018 to 2019, there was an increase in 10% of cases detection. So about the treatment for drug-resistant tuberculosis, in 2019, were the last guidelines published, the American Thoracic Society, European Respiratory Society, IDSA, and the CDC published their guidelines. These were based on meta-analysis of individual patients' data in MDR treatment. Most of these patients required at least 4 to 5 drugs, usually 5 drugs in the intensive phase of treatment, and then 4 drugs in the continuous phase of treatment. The treatment, as I mentioned before, is going to last a long time. It can go up to 24 months, a lot of pills. It's hard to tolerate for the patient, potential side effects, especially if you need to use some injectables such as an aminoglycoside. And of course, the cure rates and the mortality is still inappropriate with conventional treatments that we have. This is a graphic just to show you some of the medications that we use for the treatment of multidrug resistant tuberculosis. Quinolones, bedaquiline, linezolid, these are the 3 medications that we include usually for the multidrug resistant tuberculosis. We usually add clofazimine, cycloserine, and we have all these other drugs from group C that we can add in case some of the other medications are not well tolerated. So going back to our patient, initially when he came in, we diagnosed him with multidrug resistant tuberculosis, as I mentioned before, because of the mutations that we found, and we started him on this regimen: linezolid, levofloxacin, cycloserine, and pyridoxine. We were waiting for approval to start another regimen that I'm going to talk about. And this is something that is changing the way we are treating already drug-resistant tuberculosis. And this is this article, this paper was published in the New England Journal in March of 2020. In this paper, they tested in patients with XDR, patients that were treatment intolerant or patients that did not respond to multidrug resistant tuberculosis treatment. They tested these 3-drug regimen that included bedaquiline, pretominid, and linezolid. Bedaquiline and linezolid were medications that we were already using for the treatment of drug-resistant tuberculosis, but pretominid is one of the drugs that was approved by the FDA in 2019 to be used in combination of these 2 other medications. This study was done in South Africa, was done in 3 hospitals, so it was a multi-center study. They had 109 patients enrolled in this study, and they followed the patients for 6 to 9 months. What I want to talk about is a little bit about the mechanism of action of the bedaquiline, just to explain you quickly how it works. So because it's one of the medications that we use in this new treatment. So the bedaquiline is going to affect the ATP synthase, So it's going to prevent the mycobacteria to produce ATP. So this is the way that this is going to work. And this new medication, pretominid, one of the characteristics that has is that it's going to kill replicating and non-replicating mycobacteria, or the called persisters. So going back to this trial to the next trial. So as I mentioned, we're 109 patients enrolled in this study. XDR TB versus treatment intolerant TB or non-responsive to multidrug resistant. We use the three medications, pretomidine, bedaquiline, and linezolid. The pretomidine and bedaquiline, the dose were not modified. It was a fixed dose for the whole treatment. And linezolid, the dose could be modified after the first month based on the toxicity of the medication, and it was to the discretion of the healthcare provider. So these patients were treated with the BPAL regimen for 6 months. Some of these patients had to be, they were treated for a longer period of time based on the cultures. So if the cultures remained positive after 4 months, the treatment was extended. Some of the characteristics of these patients. So as we can see, these patients were pretty sick. These patients are similar to the ones that get admitted to our unit. The BMI of these patients in average was 20.6. We had 50%, half of the patients were HIV positive. 85% of the patients had a cavitary disease. And also, these patients were diagnosed in average 12 months before starting on this regimen. So these patients were patients that were having an advanced infection. So the outcomes of this study, they were categorized into groups: favorable outcome or unfavorable outcome. Favorable outcome was they look at the patients 6 months after they completed the BPAL treatment, and a good outcome and a favorable outcome was to have a negative culture after 6 months of being treated with the BPAL regimen. And as you can see, the numbers are impressive, are really, really good. In XDR-TB, we have a good outcome in 89% of the patients, in MDR, 92%, and overall, 90% of patients that had a negative culture after 6 months of treatment, which it's completely different than the results that we have with previous regimens.
1 minute remaining, Dr. Rico.
Sorry?
1 minute remaining.
Okay. I'm going to go quickly. So another important thing was the secondary endpoint. The median time to sputum conversion was 6 weeks. One of the downsides from this study is that we have significant toxicity from the linezolid, mainly peripheral neuropathy and anemia. There's some new studies right now going on that are trying to use lower doses of the linezolid in order to, so it's pretty much a continuation of the BPAL study, but with lower doses of the linezolid, and we're going to know the results later this year. So quickly going back to my patient, we put him on linezolid, bedaquiline, pretomidine, this BPAL treatment. He became culture negative in about 7 months after starting the treatment. In terms of his side effects, he already had neuropathy because of his diabetes, but the neuropathy did not get worse, and he remained culture negative. I presented this case because he's one of the first cases in the US that was treated with this regimen, with BPAL, and is one of the first cases in Florida. These are the places where the BPAL, this is the BPAL implementation in the US that it's been going on since 2019. These are some of the states where we're using this treatment. And so far in the US, we have 27 patients that have been treated with this regimen. We are participating in this publication that is going to happen later this year. And so far, we have 20 patients that have completed the treatment.
Thank you very much, Dr. Rico. We really appreciate this very important case presentation. I'm sorry I have to cut you short, but 1 o'clock and I know people have other places to go. So I want to thank both our speakers for an excellent grand rounds, and don't forget to sign up for the CME credit in the chat box. And I wish everybody a safe and wonderful day. Thank you.
Thanks.